Good morning, everyone, people on site and people on Teams. Today is it's a surgical grand round for global surgery, and we are very pleased for all your attendance. Today, the theme is prevention and trauma prevention. So as surgeons, we always get accused that we only deal with theater and our research is just in theater and we're boxed into theater. But we are not like that. We do think outside the box. So this is a very public health theme, but for the surgical input in a major way. We've got two presenters today. It's Dennis Mazingi and Soham. And Soham is going to be online and Dennis is on site. So introducing Dennis. Dennis is my PhD student who has a huge interest in trauma. He's a Zimbabwean citizen who did his undergraduate training in Malawi for special reasons, and then has started his postgraduate training and being a general surgery trainee in Zimbabwe. He's also very keen. He's a champion for trauma in Zimbabwe as a surgical resident, and also achieved many prizes and research prizes for his work that he's done in Zimbabwe, naming a few, which is the University of Zimbabwe Research Prize, the Abraham Harrod Prize, and also the Baitra Scholarship. So Dennis has put in a lot of effort in his PhD as well, and he's just going to share that work with us. I will introduce Soham as well so that we can kick off together, one after the other. So Soham is an academic clinical fellow in neurosurgery, but he's a big research lecturer in global surgery. Soham is a medical student from Oxford who got a distinction in his final year and very active with global surgery from student days. He's worked with our team for almost 5 or 6 years now, and he has been very prolific in developing things and writing up things. He has just not got a medical degree, but he's pursued a MSc in public health, and he's also done some training in health, business, and finance, which is very useful for the global surgery group. So I'll kick off with Dennis.
Morning, everyone. This is a bit of a full circle moment for me because the last time I was in this room, I was sitting right there in 2009 as a medical student on elective. So a lot of memories and, as I say, full circle moment. So thank you to all of my supervisors and co-supervisors for helping me with a lot of this work, and I'm just going to present some, but not all of it, otherwise we won't have much time. So this is what I'm going to go through, introducing the subject, a bit of background, and then look at the different parts, and each one will have methodology and some results, and then look at the future. So injury is a significant public health burden around the world, accounts for 4.3 million deaths annually, which is 7.6% of global deaths. And unfortunately, it's disproportionately felt in low and middle income countries, particularly continents like Africa. Africa has about 659,000 deaths. This is as of the 2021 Global Burden of Disease Study, which accounts for about 15% of global deaths. And that's about third in the world. So seems like Africa is not necessarily the highest, but getting up there in terms of continents. However, what do we really know about the burden of injury in Africa and other places? You can see here that data comes from deaths. The ultimate burden is deaths, and that's the maps that I showed you. But the coverage of deaths registration is pretty low in Africa. So it's a safe bet to think that that's an underestimate of the number of deaths due to injury, and also relative to other conditions which are relatively well counted. Africa actually probably has a much higher burden of injuries. You can see that globally, the general trend has been for a decrease in the burden of disease due to injuries from 1990 all the way to 2019. So there has been a general decrease with a few peaks here and there. However, that decrease is actually masking the fact that there is this huge disparity. So that trend that you saw, that general downward trend, is actually reversed when you look specifically at the African region, and this is for road fatalities. but it's also true of other things. And when you zoom in, you find that around 30-year period from 1990, that most of the world seems to have gone down in terms of age, all injury disability adjusted life year rates. However, and so you can see from the colors there that most of them are either blue or green, which means that they've reduced. But there's a small handful of countries, and you can see them here in yellow, which are in the 0 to 10% range. So these are countries that have either stayed the same or gone up by up to 10% since 1990. And you can see that handful of countries includes Zimbabwe. Again, another graph that shows the stark, the conspicuous nature of the Zimbabwean burden. This is percentage change in unintentional injury DALYs from 1990 to 2019. And you can see that Zimbabwe is one of very, very few countries in the world that has actually had an increase of about 50% in unintentional injury DALYs. This is for adolescents in particular. So in general, Zimbabwe has an increasing injury burden, or we think that it does. There's no surveillance system as far as we know, a declining trauma care and healthcare system with a multitude of risk factors, and essentially it's the last frontier in injury prevention. So if you want to prevent injuries and if you want to tackle that problem, Zimbabwe is really the best place in the world to do so. So how do you tackle injuries? So there's a systematic approach, which is just basically the application of the public health approach to injury. This is something that was developed for infectious diseases, first of all, but now has been applied to all sorts of different types of disease. And basically, it's a stepwise approach to quantifying problems, or identifying them, quantifying them, understanding the causes, developing and testing interventions, and ensuring widespread adoption. So this is an approach that has seen wide success in many high-income countries for reducing injuries as well as a lot of other different diseases. And you can see that Zimbabwe is really at the beginning of this journey. This is a long journey. Some countries have taken decades to traverse this journey, but Zimbabwe is really at the beginning. And so the objectives of my work really follow this public health approach to injury prevention, and hopefully will end at the end with a reduced burden, and hopefully within the deadline set by the Sustainable Development Goals, which is 2030. So we want to understand the burden of disease in Zimbabwe and the state of surveillance in the country. We want to look at other surveillance efforts in Africa and see how we can learn from them to improve surveillance in Zimbabwe. And then we want to look at how to implement and make sure that surveillance is sustainable and works. Look at some risk factors, look at barriers and facilitators along the healthcare journey, map the journey of childhood, specifically injury patients in the Zimbabwean health system, and then pilot an instrument that basically tries to quantify those risks. And you can see how the public health approach to injury prevention, which, as I said, can sometimes be a decades-long journey, maps onto not only my work, but future work that is already being planned or in progress. So, like I said, we want to look at surveillance, what's the state of surveillance, and what is the burden of disease, identify risk factors, which is part, again, of my work, you can see here, quantify and look at potential mitigating factors, then develop and institute interventions, do some advocacy among policymakers as well as among the public, scale up and then evaluate the program. And this is the ultimate plan for our group, is to either hit the 2030 Sustainable Development Goals, because there's some really important development benefits that accrue from being able to achieve those goals, but also beyond that. So the first part was, what is the burden of disease? So what do we really know about the burden of disease in Zimbabwe? To figure that out, we started a systematic review of available data sources in the country. So basically, we looked at all published literature, including grey literature, because that's where a lot of the potential data exists, which is government reports, dissertations, preprints, and other potential data. We were quite exhaustive in our search, because we really wanted to make sure that we got everything that was available, suspecting that there wasn't much. And it's true that there wasn't quite much. We were really looking for data that was either nationally or subnationally representative, that would give us an idea of burden in the whole country. And we were looking at the three major subgroups that are used by the Global Burden of Disease Study, which is unintentional injuries, transport injuries, and intentional injuries. So you can see the number of records we found and how we we whittled them down. And we found a variety of different statistics, some of them more or less representative, some of them with either good or bad disaggregation of age categories. So we have some municipal statistics for the biggest city and province. We have some mortality statistics. So we have what's called the national health profiles, that they give us mortality numbers every year in Zimbabwe. Of note, they stopped producing these reports in 2014, and you'll see why that's important a bit later. Various mortality reports, and then we have what are known as global health estimates. So these are modeled estimates of disease burden for a whole range of different diseases and a whole range of different countries that are produced almost every year. And they take basically official statistics from countries, they model it based on various assumptions and correction factors, and then they come up with a global burden of disease figure, and then they can be broken down to different countries, in some cases subnational. So obviously the veracity of these estimates depends on how good the underlying data is, okay? And as you can see from the coverage of death registrations, it's quite low in certain places in the world. It also depends on the types of statistical modeling assumptions that you make to make those models, because in a country with low data, they make certain assumptions to optimize for the global number, but sometimes that puts the national number at risk of not necessarily being as accurate as it could be. They prioritize the global burden of disease rather than the national burden of disease. So in general, this is the best available estimate, which is the Global Burden of Disease Study 2021, the latest, which shows that about 11 or more than 11,500 annual deaths from injury in the country, which is 6% of all cause deaths. You can see a very wide confidence interval there from 5 to 7 essentially. Almost 1/3 of all deaths happen in children, adolescents, and the young being up to 24. That's a definition that the Lancet uses. And Zimbabwe is about 13th highest out of 54 African countries in age-standardized all-injury death rates, and 22nd out of 204 countries and territories around the world. So we took those estimates that were nationally representative, that showed a trend over a specific amount of time, to have a look at those different estimates and to see what has happened to them. So the Global Burden of Disease Study, as I said, every year they undertake this massive modeling exercise, and they recalculate the burden of disease in different countries for different diseases based on the updates to their model. So every year there's a newly updated model that has maybe some slightly tweaked assumptions, some slightly tweaked underlying data. So that's why there's a difference between Global Burden of Disease 2017, 2019, and 2021. So that means they retrospectively will go back and recalculate the burden of disease in each country for each disease based on what they think is a relatively more accurate model with better assumptions. And you can see here that for Zimbabwe, that the only data that we have on all injuries that is nationally representative that shows us a trend is Global Burden of Disease Study. And you can see how different the different estimates are. So this is the same organization, the same disease condition in the same country, differs so much that at some point the confidence intervals don't overlap. So that means that there's a statistically significant difference between what they said was the injury burden in 2017 and what they said it was in 2019, for example. And you can see that, so 17, it was the green one. In 19, they corrected, and you can see that the burden dropped significantly. And then in 21, they seem to have corrected again, and so that increased the burden, the apparent burden over time. Road traffic deaths, you can see these are the different sources of data that we found. Some of them are government reports. Some of them come from Global Status Report on Road Safety, which have a different model that they use with slightly different assumptions. And you can just see how different the estimates are for global burden, for burden of disease in Zimbabwe for road traffic deaths. Again, there's some that don't overlap confidence intervals, which basically tells us we don't quite know what the burden of disease is in the country based on the best available estimates that we have. And the same is true for homicides and interpersonal violence. And you can see just how different some of the estimates are and how wide some of the confidence intervals are. So the uncertainty in disease estimates is basically based, as you might guess, on how good is the underlying data and how good is the model itself. So uncertainty is introduced by the model and the assumptions you make. So we wanted to quantify that uncertainty in the estimates. And you can see here that this is what's called the coefficient of variation, which is basically the amount that it's basically the width of the confidence intervals standardized for the values. And you can see just how uncertain we are about the Zimbabwean estimates, basically very uncertain. And you can see that after 2014, which is when I said the national health estimates stopped being published, the uncertainty just continues to rise. So essentially, we are increasingly uncertain about what the burden of disease is in Zimbabwe. And the same is true for road traffic deaths as well as for all injuries. Okay, so the best available estimates that we have are we're really quite uncertain about them. We're not really sure exactly what the burden of disease is. In any case, these are some interesting municipal figures. So these are from Harare, so the biggest province by far, bigger population than many of the provinces put together. It's a major metropolitan city and has a lot of the bigger hospitals. And you can see that road traffic, what they call accidents, although we don't use that word anymore, being ranked against other diseases. So this one here is HIV and HIV-associated conditions all put together. Okay, and so obviously it's the city council that collects this data, and so it's not necessarily aggregated into different health categories. It's about administrative categories, and you can see that those have been number one for quite some time. Okay, however, road traffic crashes have increased in their ranking over the years from 2005 all the way up to the latest available 2018 data, from around 6th or 7th to 2nd and possibly 1st now in the last 5 years. So there's been a steadily increasing burden of disease on the municipal level, on the city level in Zimbabwe, in that age group, and you can see that's the same here as well, okay? So essentially, there's very little research in Zimbabwe, specific to Zimbabwe, on the burden of disease. There are no population-based surveys or censuses, which are the best possible nationally representative data you can get. The primary data is inconsistent, incomplete, and has low coverage. The model data makes big assumptions and corrections, and there's a substantial burden of disease, which we're not necessarily sure that we know to a good degree of certainty. So, trauma registries are a really great way of surveilling injuries in countries. They give you good quality health facility data on each patient. They also give you good quality health system data about where they've come and what services that they've used. And they've been used really successfully in a lot of different countries, Australia being one of them, the UK being another. The US has one of the biggest trauma registries, national trauma registries. And they're a really great way of improving on the uncertainty that we've seen in the previous parts. However, implementation of registries has been extremely challenging in low and middle income countries. There's a lot of fragmentation, so everyone is making their own tool. Everyone is doing it in different ways. Many of them have been modified from existing tools in other countries, and the coverage is pretty low. So they're usually facility-based registries that only last for as long as the research funding would last that started them in the first place. So we wanted to look at registries in Africa and see how we can learn from their experiences to create our own bespoke tool to collect data in Zimbabwe, one that allows later on for some kind of integration of registries around Africa, so that hopefully we can start using a common standard of trauma registries in Africa, consolidate them, and then later consolidate them with other regional and continental registries. So we did a scoping review of trauma registry literature in Zimbabwe, suspecting that inclusion of children was low, that the tools were not designed for children, and also suspecting that there was low quality of reporting in these trauma registries, but also wanting to look at the inclusion-exclusion criteria and variables that they used, and then comparing them to other standard data sets around the world. So again, the aim was to map trauma registries in Africa, compare them to established international trauma databases, and the ultimate aim is to inform the development of a bespoke Zimbabwean tool, and ultimately to inform the development of a standard African tool that everyone can use across all countries and hospitals. So starting from 3,300 records, we ended up with around 348 records that then got further whittled down. 21 registries around, so 21 different countries, around 30 different registries around the world with varying outputs that we found. And you can see that when we split it up into the Anglophone countries, the Francophone countries, and the Lusophone, or the Portuguese-speaking countries, that there's some disparity there, right? So even though we had no language restrictions in our search, there's some disparity in terms of Francophone and Lusophone registries. But you can see that the output of trauma registries has increased significantly, even though, as we said, there's a little bit of fragmentation. The year 2000 was when, well, some say that the first registry in Africa was established, also when the injury surveillance guidelines were published by the WHO, so it's a good fiduciary point to kind of figure out where we've been since then. So we looked at a variety of different tools from all around the world. There's a WHO standardized tool, which is a quite complex tool, multiple pages, multiple variables, that is supposed to be standard, but is not really applied in many different countries. And then a variety of other different, some of them well-known, some of them less well-known tools. And we looked, and we eventually found 198 variables. 49% of them, those are variables that are found in at least 60% of all registries consistently, were considered to be kind of core variables. And then there were like about 150 which were in an expanded kind of data set that are a bit less common across all, but still, but not extremely rare, so not found in one or two tools. And only represented about 64% of the WHO data set for injury, and a much smaller percentage of things like the UK National Major Injury Registry or the US National Trauma Data Standard. So that those ones have hundreds and hundreds of variables in their core and expanded data sets, very granular, very detailed variables. And the reporting quality, as we suspected, was quite low. As I said, you can see here, this is how we arrived at our number of variables. And as I said, in future, we will be using this information to inform the design of an Africa-wide standard for trauma registries. But that's future work. And so we use this information and other information, which I'll show you in the next few slides, to create a kind of bespoke tool that we're going to use for data collection that has congruence with the WHO data set for injury. So it's a standard data set of variables that should be collected for trauma, but also has congruence with other tools in Africa. So hopefully it will help with kind of integration of registries across countries. And then also has some specific variables that matter to me in terms of my research and matter to the country and are specific to the country. So it's not just a case of having a well-designed registry form, it has to be implemented well. So implementation has been a major source of failure in registries. Many of them have failed, or when I say failed, I mean they haven't gone beyond the short level of funding that they had, so they didn't get taken up by the government, they didn't continue. Data quality has generally tended to be low, and there was low engagement of stakeholders to ensure broad ownership. The WHO has a standard registry that they have developed called the International Registry for Trauma and Emergency, and it was tried in Zimbabwe in the year 2019 or so, 2018-19. I was part of the team who tried to implement that, and it failed before it even began. Okay, so we couldn't get that registry to take off, and so we wanted to find out why is that so, because if we want to make a new registry, we need to find out why previous efforts have failed. And so we did a qualitative study of a whole variety of different people, and we thought about it in terms of the socio-ecological framework. So all the way from the individual person on the ground who collects data and the things that they face, all the way up through interpersonal, institutional, community, policy, and societal actors in the journey of this data to try and figure out barriers and facilitators for a future potential trauma registry. And so that meant junior doctors, casualty officers, government medical officers in the districts, surgeons from the Surgical Society of Zimbabwe, Zimbabwe emergency medicine specialists, medical records people, HMIS administrators, electronic health records and technology people, and policymakers to understand these logistical, political, financial, and operational barriers. And so I'm not going to bore you with a lot of the details that we got, but we got a substantial amount of data looking at basically these domains. You can see here resource constraints, so those are financial, human resource, technology, and operational resources. Then there are operational barriers, so things like how to integrate collection of data into the workflow of busy healthcare workers, regulatory issues, data quality and data sovereignty issues, and utility. So what are the data going to be used for? Okay. So next, we wanted to look at the health system journey. So how do people travel through the health system and how do they get to the places that they get to get their definitive care. Zimbabwe has a hierarchical healthcare system from primary care all the way to this newly created quinary level, and they have guidelines for what services should be provided at each of those levels, or what they want to be provided at each of those levels. So we wanted to do a qualitative study looking at the journey of patients across this health system to try and understand if there's under or overutilization of certain services and if we can improve allocative efficiency in the system. So this is the standard kind of WHO health system journey called the Emergency Care System Framework, which we used as a basis for what we called the conventional care pathway. And so you can see here the conventional care pathway is basically someone gets injured, they transport it to the first facility and second or third, as the case may be, get treated, go home. And that's an example from one of our journey maps. And we characterize some divergence from the conventional pathway, including patients who seek alternative care. So that's those who seek even if they don't find alternative care. We looked at people who had non-sequential referrals and people who had bypassed appropriate care. So these are the different types of divergence from the conventional pathway that we found. We also looked at different barriers and enablers along the patient journey that were important to understand people's healthcare utilization choices. So the next part. As we saw globally, the incidence of trauma has declined in most of the world, and that's because multiple evidence-based guidelines exist for prevention. So you can see here, it's no secret how to prevent injuries in most countries. You can see these guidelines that show exactly what evidence-based interventions exist, and they're based on risks that have been identified in high-income countries, but not necessarily in low-income countries. An example is the building regulations in the UK, which basically limit the temperature of water in taps to avoid scald burns, right? It's a great intervention. They use these kind of water temperature limiters that mix the cold and the hot, and it's saved hundreds of lives, thousands of lives over the years that it's been implemented, but doesn't really quite work in the Zimbabwean context where very few people have piped hot water, okay? So we need new risk factors, bespoke risk factors, and new interventions that work in those countries if we want to do the same thing as other countries have done. So we wanted to identify those risks through a qualitative study of patients who are admitted at major hospitals in Zimbabwe to identify context-specific risk factors and hazards and potential interventions. 43 participants were interviewed with two focus groups and some in-depth interviews across different ages, different causes of death, different education level of parents, etc. And you can see just some of the things. So this is a practice, the one with the green bucket is a practice that became popularized during COVID. Basically, inhalation of steam and you cover yourself with a blanket has led to a lot of facial burns in children and even burns of other parts of the body. Then there's the fact of these, what they call top burners, which is basically a gas tank, an LPG gas tank with one burner on top. So quite unstable, quite top heavy, and also low to the ground, so it's accessible to children. And then obviously power cuts, which are more systemic causes of that enabling environments that allow for injuries to take place, because you're having to boil water in a different place than a stove, and then you're having to carry that water, and then you're having to do all these different things that end up resulting in burns. So we've got a big framework and a lot of different interventions suggested by the people that we interviewed for what we can do about those different risks. And then finally, the culmination of all of this, which is taking all of the information from the review and the risk factors and the qualitative interviews and put it all together into the tool which I showed you before, and then piloting that tool in a prospective observational study of 3 major central hospitals in Zimbabwe through some data clerks for children aged 0 to 19 years of age. The aim was to look at the health system's delay, okay, across the journey to get care for injuries, to look at the health system flows, so how do people move through the health system and use different services, and is that appropriate? And then to quantify the risk factors, some of them that we identified earlier on. So just in summary, you can see here, we use the 3 delays framework, so that basically looks at care-seeking interval, the time from when you're injured to when you first look for care. That's conventional medical care. Then there's the health system interval that goes from your first contact to the date of admission. Then your treatment interval is how long it takes to get definitive care. And you can see here that people tend to seek care quite quickly, but get delayed during the health system interval, and then take a variable amount of time depending on the cause of injury to get their treatment. I'm a bit of a, yeah. Okay. And this is basically a Sankey diagram showing the flows through the health system. So the yellow is primary care, the blue is secondary level, the green is tertiary, and the red is the quaternary level. And so this is for all patients, but we've broken it down by burns, by road traffic crashes, by falls, and we found that there's a significant amount of overutilization of the quaternary level. So a lot of the people who end up at the district or provincial level can basically stop there and should be able to get the care that they need for the different conditions that they had, but end up going on to the central hospital. So that may indicate an overutilization of central hospital facilities. We know that it's cheaper to provide trauma care at district hospitals, closer to where the people are, cheaper for the health system and cheaper for the patient themselves. Right, so in the future, again, like we said, we're going to try and develop a consensus pediatric trauma registry for Africa, and that work is underway with the Pan-African Association of Pediatric Surgeons. And then we're also, which is you're going to hear about next, just undertaking a multi-phase research project to try and reduce childhood mortality from road traffic injuries in Zimbabwe and Tanzania. And just to remind you that this is now where we are at now, which is our future work is just starting as we speak. And yeah, thank you very much.
Thanks so much, Dennis, and thanks for the kind introduction earlier on. So I'll be talking today about an NHR-funded study exploring the dynamics of childhood injury, exploring what outcomes these children have and what access these children have to healthcare settings. And as you already heard from Dennis, there's already a host of work that is being done on this topic, preliminary, but it is very focused on a single area. So we're expanding this work to Tanzania as well, and we also now be implementing possible solutions to check their feasibility for future studies going into full-blown trials. So why are we showing you all this? You've already heard from Dennis a bit about the reason of injury, but the reason of injury isn't just localized to Zimbabwe. It's actually the leading cause of childhood death across the world. Figures from the United States just show you how much more unintentional injury causes death across all age groups compared to other types of disorders. But that makes to mind where the burden of unintentional injury, deaths, and morbidity is. And the fact is, in high-income countries, only 10% of childhood deaths due to injuries occur in those areas. The majority of deaths from childhood injuries, i.e. 90%, occur in low middle-income countries. But it's also lower that data is actually missing. So the percentage ratios that I was presenting are probably even more inflated towards LMICs. For example, there's a study about child burn mortality. You can see many countries in Africa just do not have sufficient data to provide it for this paper, even though it was released only just a few years ago. But as you can see from it, that we do have the majority of burden from child burn mortality occurs in sub-Saharan African countries, and to some degree, some Asian countries. But if you look closer, you can see that the two countries of interest, i.e. Tanzania and Zimbabwe, are among two of the countries with the highest burden of mortality from burns in the world. Now, as Dennis has already shown this figure, we have been monitoring how unintentional morbidity from injuries occurs across the world. And whilst most countries are improving in terms of their morbidity from unintentional injuries, we can see that when this data was released in 2019, the countries that were actually doing worse were Mozambique, Zimbabwe, and other African nations. And Zimbabwe, as Dennis has pointed out, was actually the worst increasing unintentional injury, or an increase of over 50% of the burden of injuries amongst children in that country. But since then, things have actually got worse, not better. And kids' weight index has actually increased in 21% in violence against children worldwide. And this is their figure. And as you can see, there's a rub of green all across the place. And when it starts to get yellow and red, it's mostly in African nations. And therefore, when you think there's a 21% rise in violence worldwide as an average, in reality, the increase is a lot more, is a lot greater in African nations. And you can see which countries are driving it: DRC, some degree Zambia, Zimbabwe and Tanzania, which are two countries of interest for us, are also seeing an increase, even though to maybe a lesser degree, and that's somewhat due to their baseline level of injuries in the first place. So injury burden is something of sufficient interest and need for us to address. But is there a financial side to it as well? Well, once again, going back to the US, data in 2017 showed that the cost of deaths from childhood injuries, and these are just the medical costs, was 153.2 million. And as we just talked about, death isn't the only thing that comes out through childhood injuries. There is a lot of morbidity. So once again, we look at the medical cost of all morbidity, it increases to 6.6 billion. But once again, the medical costs and a lot of the care for people who have injuries doesn't occur in the hospital. It occurs in the community. Also, costs of childhood injuries lead to people having to miss days of work. It leads to people not, for example, progressing as well as a kid economically or socially. And once again, in America, if you look at the total cost of injuries per year for children, it's $199 billion. Now, once again, realizing that 90% of injury burden does not occur in the USA, it occurs in LMICs. And actually, when you look at probably high-income country burden, the USA is probably only about 10% of that burden. This is actually only 1% of the cost of childhood injuries across the world. So if you factor that up, you can realize what the financial implications are for us not dealing with unintentional childhood injuries across the world. So why we focus on Tanzania and Zimbabwe? Well, there is a high incidence of injuries in both these countries, and this comes from existing records, hospital records, police records. But the data is limited. It's not comprehensive. We have an understanding of which people are turning up to these quaternary hospitals, these DDHs, what injuries they might have, but we don't know how common other injuries are that do not turn to hospital. How common is it for people to present to their local communities and get treated that way? How often is it that someone just dies on the scene and never actually comes in to hospital? Those are all data records that we do not have. And therefore, it is something that we need to fill as a data gap. There's also challenges in terms of figuring out how these individuals get access to treatment. There's long travel distances, sometimes scarce resources, and a lot of financial strain where many individuals are having out-of-pocket payments for their care. And therefore, we need to better characterize this burden so we know why people might not be going to hospitals or reporting things to the police. And therefore, is there a way for us to create this national registry that Dennis was talking about with the local resources, the local infrastructure set up? Because if we're having to implement processes that aren't feasible because of a scarce resource and the financial strain, will not be sustainable beyond the essence of this round. So it's all about what's currently present. So what can we institute that works with local resources? With all the policy gap, both Zimbabwe and Tanzania have committed to making childhood injury prevention some of their priorities. But to do that, they need better evidence to guide action and implementation. So, well, another one, so we had the data. We had the data on what injuries occur, where they occur, who they occur for, where people go to get their injuries treated, how do they get it treated, how much does it cost. The cost benefit of treating injuries or preventing injuries outweighs doing nothing, which, as we learned from other studies, it probably will. It's going to prove that for all stakeholders in these countries. To design implementation programs to reduce the burden of injury, both in a primary, secondary, and tertiary way. So primary prevention will be reducing injuries from happening in the first place. Secondary prevention will be reducing the morbidity of injuries that do occur. And tertiary prevention will be ensuring that these people who have the injuries have better recoveries, and therefore there is less further decline in their health and better ability to go back in the future work. So there's a lot of that prevention at all levels. And to do that, we need better care. And when I say better care, I don't mean just medical care, but also better care in the education system, in the urban infrastructure, and how we think and design how school children might go to schools, how we think of school like they safely, how we think and design and allow people live and what I will do to have if you have a young child earns by heating equipment. So it's all like better care across the whole system. Like feeding our data to governments that make policy to make that happen. But to do that, we need to get this data, prove that it's feasible, acceptable, and then hopefully go on to future trial data with governmental and NGO partnership. So our project aims are fourfold and doesn't come across the best way on full screen. The sensing just less than burdened and drivers to childhood injuries across age groups, geography, and socio-demographic status, as we anticipate this to be different across all three of these various categories. Number 2, develop, implement. And when you say evaluate, we don't mean look at its effectiveness, but look at whether that is feasible and acceptable to the local population with child injury prevention. And then we will scale up across communities in future projects, and you will then check its efficacy and effectiveness. Number 3, to estimate the cost of service delivery and therefore produce cost-benefit analyses, utility analyses, economic evaluations that will hopefully apply governments to prepare and argue for funding in this area. Number 4, develop a capacity building program both for research and the doing research, but also for training and healthcare in general. We anticipate that this will generate knowledge, both in terms of how to be better care for children, but also we're doing a lot of innovative methodologies that you'll hear about in future lectures, I'm sure. Look at what the burden of disease is, how we can track the burden of disease, how we can ensure that we have a proper grasp of where people go to meet their healthcare needs. And hopefully this will advance methodological approaches in child trauma science in other countries. We're also aiming to use the majority of our funding. When I say the majority, I mean 80% of our funding will LMIC countries. So there'll be an improved research capacity at these LMIC countries because the funding will be used to develop the local infrastructure, the local universities, the local teams doing the research. And therefore there will be a transition of skills to the local teams so they can carry on doing this work without us possibly in the upcoming decades. There's also a lot of translation and adoption of all this across not just the areas that are working, but actually across other areas in the country that we might not be able to get to. And hopefully showing to the government how best to collect that data, how best to implement interventions and judge them objectively. And also it builds a network, not just for us, but also within each country of where people could reach out to get that guidance and therefore create a clinician network and also a patient network. Because we know from what I've done in ICOM countries that when patients get together after they've suffered similar healthcare burdens, they've got similar needs and similar questions. And those questions can often be best answered by those who've gone through that journey themselves. We anticipate the benefits will both be for health, be for economic, but will also be in the rounds of research. And hopefully in the next years, you'll be able to see those tangible benefits come to fruition, and I'll be able to talk to you about them as well. So thank you very much for listening to this very brief presentation about what the NIHR funded project on reducing injury burden in Tanzania and Zimbabwe is all about. Into any questions. Thank you very much.